Okay. Good afternoon, all of you. And that the video you just saw is the landmark event of the situation of stillbirths in the world, published in Lancet in 2016. So this is the landmark point of the stillbirth, the focus of a stillbirth in the world, where it, as mentioned in the video, it caught the importance of stillbirths. The 2.6 billion was the estimated number of stillbirths in 2016. So we will see what happened since then in the world. Next slide, please. So how do we know about the global situation of the stillbirth? In 2020 and in 2022, UN Interagency Group of Child Mortality Estimate published 2 reports on stillbirths based on available data. The first one, a neglected tragedy, the global burden of stillbirths in 2020, was published after this Lancet series in 2016, giving some alarming figures of stillbirths in many of the countries. Then after 2 years, that last year, again UN Interagency Group for Child Mortality published the second report on never forgotten the situation of stillbirths around the globe. These 2 reports gives the world the estimations of stillbirths and gives some idea of how big this issue is. Next slide, please. According to the newest publication, every year nearly 2 million babies is stillborn. That means each day 5,000 women lose a baby, unborn baby, all over the world. But issue is the 84% of these stillbirths occur in low and middle income countries. And 3 in 4 occur in sub-Saharan Africa and Southern Asia. We live in Southern Asia. So even in developed countries, the risk of stillbirth is highest in the most vulnerable populations. When we see, when these stillbirths happen, 2 in 5 of these babies die during labor, what is known as intrapartum stillbirths. Most of these babies are in term. That means well mature babies. Next slide, please. In other words, every minute, nearly 4 babies die. Every hour, over 200 babies die. As I said, every day, over 5,000, and every year, nearly 1.9 million children are stillborn. So it is a very big global burden or loss of pregnancies. Next slide, please. But still, it is an invisible issue. Although we are losing 1.9 million babies every year, stillbirth prevention, although it should be a part of RMNCAH continuum, but often it is not included in public health plans or communication platforms. Many countries do not regularly collect or produce quality data on stillbirths. Globally comparable cause of stillbirth estimates cannot be generated due to lack of data and of a unified death classification systems. Many governments have not set the stillbirth reduction targets for developed when developing plans to prevent stillbirths. And it is because no data, not included in the plans, therefore not accountable for action. The stillbirth is an invisible issue, although many women and families are suffering. Next slide, please. But fortunately, this silence has ended now. Now the United Nations recognize the stillbirth rate as a core progress indicator for global health. It is clearly mentioned in the United Nations Global Strategy for Women's, Children's and Adolescent Health 2016-2030 and Every Newborn Action Plan 2014-2015. Now people or the global community has started to see the progress of stillbirth targets setting and measured through the joint INAP Every Newborn Action Plan and EPMM, Ending Preventable Maternal Mortality Tracking Tools. And as I mentioned earlier, now United Nations interagency group started to produce stillbirth estimates and demonstrate the need for collaborative work and action. Then UNICEF, WHO and partners has already called for renewed efforts to end preventable stillbirths. So now people are focusing, people are talking, and people start to measuring it. So now we have ended the silence. We will see what has happened now. Next slide, please. Then globally, we have some targets now. Although SDG does not have a target related to stillbirth, but Every Newborn Action Plan has a target. That target says each country needs to reach less than 12 stillbirths per 1,000 total births in 2030. In that way, they target global stillbirth globally less than 9 stillbirths per 1,000 total births by 2030. So it is included in Every Newborn Action Plan and the monitoring and evaluation framework for global strategy for women's, children's and adolescent health also. So now we have a target, so people start to measure it. Again, next slide, please. Then what is stillbirth? Is it different from neonatal death? Is it different from infant death? So according to the International Classification of Diseases, 11th revision, stillbirth is a baby born with no signs of life at 22 or more completed weeks of gestation. According to ICD-11, there are two categories of stillbirths according to the gestational age: early gestational stillbirth and late gestational stillbirth. Early gestational stillbirths are the stillbirths occur at 22 to 27 completed weeks of gestation. Late gestational stillbirths are at 28 or more completed week of gestation. But because of the data availability and measurement, for purposes of international comparison, United Nations interagency group define stillbirth for estimates, or they consider only late gestational stillbirths 4 estimates. So that means in all these estimates, they consider only late gestational stillbirths, which means at 28 or more completed weeks of gestation. So it's true that using this definition underestimate the real burden of stillbirths because it exclude those that occur 22nd to 27 weeks of gestation. But at the moment, this is the best available data we can use for international comparisons. Next slide, please. So for therefore, in the stillbirth definition, it is critical to, the timing is critical component of clear definition of stillbirth. Next slide, please. In this slide, the same definitions, it gives you some kind of a clear timeline and when it happened and how it defined. I'm sure Dr. Kusum will explain it in a more in her presentation. Therefore, I will not go in more detail, but I give little bit more information about what is intrapartum stillbirth and what is antepartum stillbirths. If a stillbirth happen before the onset of labor, we define it as a antepartum stillbirth. If the stillbirth occur after onset of labor, before birth, it is called intrapartum stillbirth. So there are something called early fetal stage, early stillbirths, and then the late fetal stage, that means after 28 weeks, late stillbirths, and late stillbirths we divided into 2 groups, like antepartum stillbirths and the intrapartum stillbirths. Next slide, please. See the trends in global stillbirth rates during last 20 years. We have progressed well. Since year 2000 to 2021, we almost reduced almost 1 million stillbirths. Stillbirth rate has reduced from 21.3 to 13.9. Good progress. The next slide, please. This is our regional stillbirth rates and the comparison. Our region, Sierra region, our stillbirth rate is around 14, and there are countries below the regional stillbirth rate, and there are countries at or above the regional stillbirth rate. But our target is to reduce 12 by 2030. Next slide, please. Another click. Okay, another. So globally, stillbirth has reduced from 33% reduction during last 20 years. But when we consider the Southeast Asian region, we are good, and we have achieved almost 50% reduction. So that means even when we consider only in our region, we have contributed 500,000. No, it's around 300,000 reduction in stillbirths when compared to 2015 by 2019. Okay, next slide, please. Actually, if we keep our momentum like this, we are sure that the Southeast Asian region can achieve the SDG target of 9. But we need to consider these projections are before the COVID pandemic. So we need to think what is the effect of COVID-19 pandemic on these rates now. So we need to reevaluate and see what will happen. Next slide. When we consider the countries, the stillbirth reduction is vary from country to country. Some countries has given a very steep reduction. Some countries has not shown that kind of a reduction, but it is good to see that all countries has relatively decreasing trend, but there are a lot to do for the further reduction. Next slide, please. So, as I said earlier, INAP and EPMM has targets and milestones for 2020 to 2025. So these are the few targets. So that these targets are focusing on antenatal visits. So they see all the countries should focus on 4 antenatal visits. And every birth should be attended by the skilled birth attendants, and every pregnant woman with obstetric complications, a health facility should be available within 2 hours travel time for every pregnant woman for the management of obstetric complications. So accordingly, they have put this global target. So these are the 3 main areas you need to focus on if a country needs to reduce stillbirths. Next slide, please. If we not act, next decade, again, 19 million babies will die in utero. They will not born. So therefore, eliminating preventable stillbirths require increasing awareness, support quality care during pregnancy and childbirth, supporting bereaved women and families, as well as measuring every stillbirth. So with the next presentation, we will listen what are the things we can do to prevent these stillbirths. Next slide, please. Thank you.
So then what are the intervention and strategies for prevention and management of stillbirths? So let's see. It's just a summary slide of what Dr. Hemachandra presented. In 2020, stillbirth estimate indicates slow progress in all over the world, but our region is little different. We have done some, but we also have to be expedite the annual rate of reduction. In SEA region, 6 countries already achieved the 2030 national stillbirth target. So we know that stillbirth rate, even though whatever this is a measurement, but it's an important mark of quality of care in the pregnancy and childbirth. So if it's a one indicator, if you want to see the quality of care, what you provided during pregnancy and childbirth, stillbirth is a marker, and the intrapartum stillbirth rate is a real good indicator to be measure your quality of care. So then how can we do? Do we know that what we have to do? Then scaling up of these evidence-based interventions in a population is key to reduction of stillbirth. So this is not the intervening or actions. This is the evidence-based intervention I will talk later. So, and also what is the next thing that we increasingly recognize, that improving maternal and infant outcome or a perinatal outcome that strategies that target factors across the life course and not exclusively in the prenatal period. So if you want to reduce these stillbirths or perinatal deaths, so you have to do intervention throughout the life cycle and not only the antenatal period. So this is again an important area we need to see. This is just a summary of that what Dr. Nilmini presented. And that if you see these 4 scenarios, what you see that scenario 1, so no change, then 22.1 million babies stillborn by 2030. So if you continue like this, if the scenario 2, current trends maintain, 2.6 million babies saved, at least that you are not expediting. And then in scenario 3, if you accelerate the progress and then all these evidence-based interventions, then you can save 5.6 million babies. And then with better measurement and stillbirth intervention prioritized, then you can do that. But if you move into the high income scenario 4, that high income country match, then you can save the 12.2 million babies. So then this is up to us that we want to be in the scenario 1 or scenario either 3 or 4. So, and then if you look at about causes and risk factors for stillbirth for prevention, so the main important thing is access to health services, quality antenatal care, number of visits, and during pregnancy, quality care during labor and childbirth. This is extremely important. So then maternal fertility-related conditions like complication during birth, antepartum hemorrhage, placental abruption, maternal age, fetal growth restriction, then prevention of infections in maternal condition, malaria, syphilis, HIV, obesity, diabetes, hypertension, and sickle cell disease. These are the proven factors, risk factors for a stillbirths. And in addition to that, there are lifestyle choices also. We will talk it a little later. Then socio-economic determinants that we have seen, as Dr. Hemachandra's presentation, she mentioned that is most of these stillbirths happening in underprivileged countries and or low middle income countries or developing countries, and then rural residences, migration status, sexual physical violent assault is associated with that, ethnicity, there is a relationship that consanguinity and economic status. So this is again stillbirth happening in rich people as well as the poor people, but majority still happening in underprivileged settings. And also there are environmental impacts, also exposure to high temperature, indoor and outdoor air pollution. So don't think about this is sometimes it's not easy to be removed, but first there are several factors that you can reduce, you can do intervention before we come to this stage. So, so what are these stillbirth effective evidence-based intervention? If you categorize, there are 15 now. If you categorize 10, if you take out 10, you can see that. So this is stillbirth prevention for antepartum effect and also interpartum effect. That means the antepartum stillbirth prevention and the interpartum prevention. Then periconceptual folic acid fortification, we can reduce 41% of this. It's a very cheap drug, and then but you need a lot of intervention. You mean the programmatic effort to be included that. And then also, if you look at other things that emergency obstetric care, you can see that routine induction to prevent postpartum pregnancies, that you can see 69% effect size. And then also skill care at birth and basic emergency obstetric care. Dr. Hemachandra mentioned about that. Comprehensive emergency obstetric care, 75%. So you don't need to be memorized it, but if you have little money, then you can prioritize where you should be to be put the intervention. This is extremely important to understand. And then this is, you can deliver through the basic antenatal care or advanced antenatal care, that these interventions, and then also obstetric care or interpartum care. So these are the proven effect size of these evidence-based intervention for stillbirth reduction. So if you see the preconception care, that folic acid, that you have to be put it into the preconception care. So you can see, but the problem is that only the in this here, maintain, improve health and nutrition, including folic acid intake during the pre-conception period, before get. And then also improve family planning services. And then also spacing. These things are quite important. And then also adolescent pregnancies and protect girls and promote adolescent health. So these things you have to start before they get pregnant. But the problem is few countries only have the preconception care program. But this is again an area we need to think when you want to reduce stillbirths. And the other thing is the pregnancy care, antenatal care and the interpartum care. Mainly, it's important to have the birth preparedness plan. That even antenatal care recommendation I'll come later. Then this is area that we need to have a birth preparedness plan, and then to be discussed during the antenatal period. And then also there are several things. I'm not going to talk about everything. You can see that there are so many things you have to do during antenatal period. And then also monitor and manage fetal growth restriction, also again important. And then management of obesity, diabetics and hypertension is important. And then also train healthcare worker midwives to provide appropriate preventive care and support in case of stillbirth. So that's why even that now earlier that they say that 1 antenatal care, then they say that 4 antenatal focus antenatal visit. Now they say at least you must have 8 antenatal visit. So these 8 antenatal visit, they allocated 5 visits for the 3rd trimester. This one reason for this 8 antenatal visit in 2016 WHO recommendation is mainly for this to reduction of perinatal death or a stillbirth. So this is again extremely important, 8 visit and more visit in the 3rd trimester. And then these visits are not just contacts, it's really contact, not the visit. And then you have to provide the all these recommendations proposed by the WHO. So then interpartum care and emergency obstetric care also extremely important for reduction of stillbirths, is mainly the intrapartum stillbirths. So then there are so many things that providing intrapartum monitoring, and there are WHO 2018 recommendation, I'll talk little later. So then also cesarean delivery, post-term labor induction, there are some recommendations related to this intrapartum care and emergency care. And then the postnatal care, what do you mean by in the postnatal care after the stillbirth? Then again, this is high quality postnatal care is important even for after the baby died. And then also, and the perinatal death, following the perinatal death, what they should do. And then perinatal death audit also comes here. And then Dr. Kusum Thapa will talk about this. All these things has to be provided within the respectful care. So now you understand that even stillbirth prevention, it has to be integrated into the several programs of the life cycle, that some in the preconception, some during the antenatal period, some during the interpartum care or a labor care, and then some for the postnatal care. So therefore, that is there's so many programs has to work together if you want to really reduce or prevent stillbirth. So then how can you identify these 10 interventions? So there are again science behind this. And if you see, if your stillbirth rate is very low, that means 5 to 14.9 is not very low, it's low. And then it's very high, mean that more than 25. And then in between is 15 to 24. So if you have little money and based on your stillbirth rate, the status of stillbirth rate, then you can identify the intervention. So then this intrapartum care or emergency obstetric care interventions, you have to apply at all SBR level. That means even you are having the low level or intermediate or high level, then it has effect on stillbirth reduction. But if you have low and moderate SBR level, then you have to put it this ANC interventions. And then management of diabetic and all these things is having effect only at the, if your stillbirth level is very low. That does not mean you are, when the mother comes with diabetics to the antenatal clinic, you are not going to manage. I'm talking about the national program. If a national program is going to prioritize the interventions, then you can identify your stillbirth level and then see the what are the interventions you must have intervene as start in the national program at immediately, and then if you get more money, then you can start the next level, and then if you're getting if your rate is going down, then you can select all these interventions. So this is just how to do prioritize, but not to get confused, but then these are evidences available in the world. So so if you really want to implement, if you really want to reduce stillbirth at today, and then you look at your stillbirth level, and then also this specifically emergency obstetric care and cesarean sections reduce the highest number of stillbirth and should be the first priority, especially because of additional benefit to women and neonate. It's a triple investment. If you invest on and intrapartum care, and emergency obstetric care, it has a triple investment for the reduction of maternal mortality, reduction of stillbirth, and the reduction of early neonatal deaths. So this is just what I just want to highlight here. These countries, how it's in Sierra region. This green countries has already achieved their 2030 target. They have already achieved, and the yellow countries, they are at the current ARR, annual rate of reduction continues, or they will maintain it or accelerate it. They can achieve the 2030 target, including CR region. And then the red countries, you have to be seriously expedite to annual rate of reduction. So you can see that latest annual rate of reduction, only 3 countries are 2 countries are green. That means they are having at least 4 and above ARR. And then if you want to achieve in 2030 target or maintain this, others has to be expedite. So I just want to match and see this. There are 15 interventions. Out of that, I have explained 10 interventions with effect size. If you see this country that is red, that means stillbirth rate is quite high. And then with this particular ARR, they're not going to achieve the 2030 target. But if you see the ANC coverage, at least for 4 visits, not for 8 visits, and institutional deliveries, you can see it's quite low. And then also here also you can see they are going to achieve, but if you expedite, if you maintain the ARR, but you can see that they have to work on ANC. If their ANC coverage is quite low, but even though their institutional deliveries is high. So if you map the coverage of all these interventions that what I have mentioned in the previous slide, you can see where you should achieve, where you should at even the Myanmar, you can see that you need to act on ANC plus institutional delivery plus other interventions also. When you map it, you see that where you need to be act on. So this is just to see that the evidences is proven even with our data. So these 10 interventions I have mentioned earlier, you can see that these interventions, you can see when you map it for the country, then you know that where is the gap, and then you need to be act on those things. Act on, put the intervention, you mean the activities to increase the coverage. So then what WHO has done? Whether WHO has given any guidance? Yes. WHO recommendation has released on antenatal care for 2016. This include all these visits and then 46 interventions, recommendations, and the intrapartum care for a positive pregnancy experience also in 2018. And postnatal care actually is not much effect on stillbirth, but if they talk about the even the bereavement care and the stillbirth investigation and the labor care guide in 2021. So these things has given all WHO evidence-based recommendations to be implemented in a country if you really want to reduce maternal deaths as well as the stillbirths, perinatal deaths, as well as the early neonatal or perinatal deaths. And then also this quality of care framework also has issued by WHO. And then they talked about what should be the standards for care in this when you implementing the these recommendations. And then also prevention and elimination of disrespect and abuse during the facility-based childbirth. That is also, they have found that it's important for us stillbirth reduction. And then based on all these recommendations, we have developed a regional strategic framework for accelerating universal access to reproductive health in WHO Southeast Asia region. This has a good account for stillbirth prevention included and published. So if you want to look at the stillbirth reduction, what we have to do, this is again area you need to be, you can look into that when you want to have your national plans. And then also, as Dr. Nilmini presented, that is never forgotten that new stillbirth estimate also, they have talked about all these strategies. So way forward of stillbirth prevention. So what we have to do? So if you want to really reduce, we have to develop national policy. You need to see that whether your national policies is there any gaps or that policy is favorable. Then RMNCAH policy survey you have completed. That's I like to congratulate Myanmar. And even with all this, I know there are some issues that in that still that Myanmar has completed RMNCAH policy survey. That these findings you can use and see that whether is there any gaps in the policies. And then also strategies and plans for stillbirth reduction along with the relevant programs, and integrate stillbirth specific component with the relevant plans. That this preconceptual care component has to be go to the either adolescent or preconception care, and then antenatal care for the antenatal part and interpartum care like that. You need to see the recommendations for the stillbirth reduction and then to be integrated into the specific area of the plan. Then the most important thing, why this stillbirth is a neglected issue. So we don't have sometimes focal point. We don't have a focal point for the stillbirth reduction. So we need to identify a dedicated focal point for stillbirth prevention and surveillance. This ideally within the maternal care program. So what has happened in the most countries, I can't remember in the exact the Myanmar situation, because this stillbirth target, we are talking in the enough target, every newborn action plan. So they found the stillbirth focal point from the newborn health program. Then sometimes, then what is happening that the intervention for stillbirth prevention is usually with the maternal care program. So then the counting is only with the newborn health program. Then there may be some clashes and then coordination issues. And therefore, we recommend ideally that stillbirth focal point should be stationed in the maternal care program. And then you need to set targets. So national and subnational target for stillbirth reduction in line with the global target. So we need to reduce more than 12. And then so that if the subnational targets, subnational areas also like the provinces or states or whatever, and then you need better to have that their targets. So this is again an important area if you want to really reduce stillbirth. Then we need to identify the relevant package of evidence-based interventions. It's already globally identified. Then you need to see the relevant package intervention, and also you need to map and see the coverage. As I mentioned, that two indicators in all these zero region, how it's behaving, but you can map all these 10 or 15 evidence-based interventions, what are their coverage, and see where is the gap. That is the most important from. And then other important area is support for bereavement women. After the stillbirth, I know, I personally experienced neonatal deaths. I know how difficult it is. And then after that, that you need to support for that woman or a lady. So then this is again a new area that we need to be think about our program. Then improve measurement. If you don't know, as Dr. Hemachandra mentioned, if you don't know the number of stillbirths, and if you don't know why they died, and then you cannot do anything. So then improve measurement and stillbirth and the response. I think Dr. Kusum Thapa will talk about this. I think it's extremely important. Count and then act on that. And then also strengthen health system. So all these things, all these interventions, even though these interventions you identify, you have to deliver through health system. And then health system is the vehicle. So then system strengthening to provide quality ANC, intrapartum care, and achieving equity within the countries and regions through a sustained investment. So this is linkage to quality of care and perinatal death surveillance and response. This is again a very, very important, big area. I can nicely say that simply that strengthen health system is difficult, but yet without health system, we cannot deliver anything. So this is again important. If you summarize like that, if you want to reduce stillbirths, if you act on these steps, you can reach into these targets. But what is the situation in our region? But in stillbirth identified as a public health problem only in 73% of the countries. But I think Myanmar it was identified as a public health problem. National program for prevention of stillbirths only in some countries. And national health plan includes stillbirths in 82% of the countries. That's really good. Integrated national stillbirth program in 91% of the countries, and the focal point person in RMNCAH, including stillbirth, is 100% of the countries. But yet you please look at that, where is this focal point? And stillbirth is in the CRVS system is only in the 36% of the countries. That's a long way to go. So this is from RMNCAH policy survey. Now this new survey comes, then we can see that whether how we have improved, whether we have improved or not. So there are so many that if you want to reduce stillbirth, we have to raise the voices, increasing awareness, reducing stigma, taboo, and misconception. There are a lot of stigma and taboo related to the stillbirth. So what are these? So these misconceptions and we have to identify. Then what are these misconceptions? Stillbirth is a natural event. They think that like a delivery or a birth, live birth, stillbirth also can happen. And prevention of stillbirth is expensive, very expensive. We cannot do it. Only for the high income countries, you have to think about stillbirth. Then talking about stillbirth is insensitive. So these are misconceptions. So we need to be addressed for those. Then also social taboos, stigmas and silence of families. So I know that some, even in the very developed countries, even the rural and urban areas, there are a lot of social taboos and stigmas related to stillbirth. So we need to think about those things also. And also other things also, intrapartum stillbirth is most of the time is related to our quality of care. Then women should demand for high quality, respectful maternity care for a competent health workers. So this is again an area that we need to think about. And also, as I mentioned, we have to provide the emotional support through the community, religious groups and family. We should not just neglect it and then think it's as a normal event after the stillbirth or a neonatal death. It's such a the trauma for the mother and the family. So we need to understand and provide the care. Care should include those areas also. I'll end with the statement from our Director General of WHO. Each stillbirth is a devastating experience, causing untold heartbreak for millions of families around the world. Every woman, no matter where she lives, needs high quality care and monitoring during pregnancy and labor to reduce risk for herself and her baby. So we need to think about it. We know what to do, but we have to act today, and then we can't wait till tomorrow. And then because there are so many babies are losing. Thank you very much.
Good morning, good afternoon, everyone. It's really a pleasure being here and being able to discuss this very important and interesting topic. And I would really like to take this opportunity to thank WHO for giving me this floor to be able to share my thoughts. So we've heard about from the previous eminent speakers on the magnitude of the problem and strategies to address the problems of stillbirth. We've also heard about the efforts to really break the silence and the need to do that. However, we still feel that many countries are not regularly collecting and producing quality data. And Anoma just mentioned that there is this need to really improve measurement. Can we have the next slide, please? I would really not like to go through the slide because Nilmini has really explained at length in this, and this really highlights the magnitude of the problem, what we are talking about today, and all of us gathered here for this important cause. Next, please. Next. Next, please. So just, no, the previous slide, please. Yeah. So I just would want to really emphasize here that among the many challenges of collecting data on stillbirth, one very important thing which I will be talking today is regarding the poor knowledge, limited understanding, inadequate training abilities to report births and fetal death. And we all know that if we do not accurately measure and correctly assign the cause of death, any response we formulate would not be directed to really prevent future similar deaths. So this is really important to be able to correctly assign the cause of death and really be able to measure these stillbirths. Next, please. Next. So among the strategies to drive sustainable change and end preventable, one of this is really to build the knowledge through better measurement of stillbirths. And for this, as we really correctly said, that it's the frontline health workers, subnational managers, they really need to have this capacity to be able to do this. So in an effort to address this capacity issues, what MCGL along with WHO, UNFPA, UNICEF, we've really worked together. Can we have the next slide, please? To develop this capacity building package, which is an integrated package of MPDSR, and that really has sessions which are focused on really the correct classification of the cause of death. And so we have the virtual packages as well as the in-person package, which will be very shortly available for all of you all. Next, please. So to really improve collection, we have this ICD-PM classification system. And what the ICD-PM classification does is it really facilitates a consistent collection, analysis, and interpretation of the information of perinatal death. And when we mean perinatal death, we also, that the most important component is, of course, the stillbirth. So for the perinatal death, it really captures the timing of death. Is it antepartum? Is it intrapartum stillbirth? Or is the death happening during the neonatal period? It has a multi-layered approach to identify a single underlying cause of death. And it links what is really important and interesting is it's linking the perinatal deaths with maternal conditions. So that if you can correctly assign the cause, and I will show you examples, you can really then formulate a correct response plan. Because it's important to assign, to measure, but also equally important is to formulate response plan, implement, and follow up on the response plan to prevent future deaths. Next, please. I'm not going to repeat this, but all what I want to highlight is for the stillbirths, we are in the training and in the capacity building packages, we are asking for the 28 completed weeks, though now the ICD-11 also mentions early stillbirth definition of 22 weeks. We are also making sure that all the stillbirths are counted and classified as per antepartum and intrapartum. So the capacity building package, which I've just mentioned, and the capacity building activities which goes with it, is really emphasizing on this important aspect. And I'm just sharing this because this is part of a reference aid in the package, and all the facilities and countries where we are training, they have this as part of their wall chart so that it's for quick understanding. Next, please. The next thing is like, we have this prepared this job aid to really help facilitate frontline health workers in correctly classifying them according to the different causes. So if you look at the green box, that's the stillbirths, whereas the blue box is the neonatal deaths. And lower down, what you can see is from M1 to M5, those are the maternal conditions. So every death needs to be classified as per the stillbirths and linked with the maternal condition. Is it a healthy mother? Did the mother have any other complications during labor or delivery? Did the mother have complications during pregnancy? So that would be all linked together. Now, if you look at the green box, what we've really done is had classifications for antepartum stillbirths and intrapartum stillbirths. And the antepartum goes from A1 to A6, and intrapartum is from I1 to I7. So that way, correct classification, and providers don't need to remember all this. This job aid is there, which will help facilitate them and put the stillbirths in the correct category so that correct response plan can be formulated. Next, please. So this is what the maternal condition is, and this is also part of the job aid, so that if there are, if the stillbirth is associated with any maternal conditions, then the action plan which is formulated would be also directed towards what maternal complication was there and how we can do to improve and strengthen care for the mother so that you prevent the next stillbirth. Next. I would just like to walk you through an example of what has been done, a country example, and I'm taking Nepal as the country example on the MPDSR system strengthening modality. So if you really look at it, what we do is we do a baseline assessment for MPDSR, and we have standardized tool, which has been well tested. It is from USAID's MCSP progress monitoring tool, and that's the tool we use to assess the baseline of all the facilities where we implement. And what you can see here is an important aspect, because building capacity of these frontline health workers to be really able to do this MPDSR process, which includes correct classification of the cause of death of both ICD-MM and using the ICD-MM and ICD-PM classification system. So we have this capacity building activity. We also have an activity which really strengthens the committees, and the committees then ensure that this correct classification is really done, and they work as a team in doing that. And going back to what Anoma just mentioned, having a focal point for stillbirth housed within the maternity unit is crucial, and that's also something that the member secretary of this committee in Nepal is the maternity nurse in charge. And so she ensures that all the deaths are recorded and correct classification is done by the committee. It's important that the use of MPDSR scorecard, and I'll talk about the scorecard later, but as the job aids, which I've just mentioned earlier, that is really used to really ensure that the cause assignment is done correctly. Based on the cause assignment, they formulate a response plan, which then this whole thing gets into the web-based reporting system in the country, and they implement it, and through the web-based system, they are also continuously refining their response plan. And what Anoma just mentioned is the strong linkages with quality improvement is also so important. What we feel is for the correct assignment of the cause, one-time training is really not very effective. So it is effective, but that's not enough, sorry. It's not enough. So ongoing mentorship is really important. So if any countries really want to use this process, they have to ensure that along with the capacity building, we have to ensure link it with mentorship so that this ongoing mentorship is really important. And ongoing mentorship can be done both virtually or on site, and this is what we've been doing. Next, please. The forms, it's important that countries, when they design their forms, they should have a section in which the cause of death is there so that we do not miss out any stillbirths or neonatal deaths, because and that facilitates classification system. For example, when you're looking at this form, there is a section on antepartum deaths, intrapartum deaths, neonatal deaths, and maternal conditions. So the form itself has this ICD-PM system built into it, so that at the end, like if you can see the red arrow, they then, based on this, they will just circle it, and then they write whether is it A1M0 or A1 A3M2, whatever is there, they just circle and then they put it there. Next. So this then gets transferred into the aggregated facilities are doing an aggregated classification of the death, like the perinatal deaths, stillbirths. In a month, you can have so many. So what they do is, this is a form which then populates all the deaths in a single form, so that, as I'll show you later, we can really visualize it well and use this information to inform, use the data to inform decisions and inform the response plan. So for perinatal, this aggregated classification system is used, and this form is used, and it's done on a monthly basis by the facilities. Next, please. So if you really look at it, this is an example of one of the big referral hospitals. The red circles are like, okay, this hospital had 12.9% were antepartum hypoxia. And then you had 41 deaths were due to unspecified cause. And this is very, very important, because if you get a huge number of unspecified cause, then you, I mean, like as the committee really needs to look at it on what is happening. Why are we not being able to specify the cause of death? And there could be various reasons. And sometimes they mention that it was antepartum stillbirth. When they came to the facility, they didn't have a fetal heart. And so I think it's more important for us to really look into this. And if you look at the intrapartum, like they had 6 deaths with acute intrapartum event, and which Anoma just highlighted about the strategies on how you want to improve your intrapartum care. Next. This is another big hospital, and you can see the aggregated responses. So I think what is really important, and what I would like to say, is looking at it this way really helps you in identifying what the underlying cause is, so that if you can then formulate correct response plan to address that. Next. So based on the ICD classification, the 2 hospitals, the medical college, they said that as a result of the audit finding, which showed high stillbirth, and they had also neonatal deaths, they added new systems and equipment such as fetal monitoring, labor room, and this is what they've said. Like even additional human resource, and they were able to do this because this is a private medical college, and ventilator support for NICU. At Kosi Zonal Hospital, which is a government hospital, they said that to address higher antepartum deaths, the hospital is coordinating with the health office in the district to raise awareness on antenatal care, because most of the, what they mentioned was most of the antepartum deaths were like, they were coming from outside. So they tried to map it out and then work with the health offices. And also they wanted to really improve the quality of antenatal care in their own hospitals, including counseling on the pregnant mothers on birth preparedness, complication readiness, and improve their counseling. So this was the action plan they formulated. They would want to implement it. And there is a mechanism we have in place in which we can see whether that has been followed up or not. Next. So this is the scorecard. And if you look at the indicators, which was the first is maternal perinatal indicators. There are review indicators and use of evidence and recommendations indicators on these. These indicators are all taken from the WHO Global Implementation Guide, MPDSR Implementation Guide, from the catalog of indicators which WHO has. And we selected few indicators which would be meaningful for us and feasible for us to be able to capture. And if you can see that we've really ensured that we include a number of perinatal deaths on a monthly basis, the proportion of perinatal deaths assigned by cause, that is the ICD-PM, number of stillbirths, we are counting them, that is antepartum, intrapartum, and neonatal. So disaggregated perinatal deaths was also important. And this is being done by hospitals on a monthly basis. It's done by the district. The districts looks at the hospitals in the catchment area. The province looks at all the districts. So this is a system which is now getting into the web-based system, so that each of the districts, each of the province across the country, they can look at their own data, and the facilities can look at their own data over time. And we have also recommendations in which we said that the proportion of recommendation implemented based on the perinatal death reviews and also follow-up. So this goes into the web-based system. It is linked with the forms which gets uploaded in the web-based system. So there's no additional effort needed to really populate this, but they can click on this and they can visualize their data. Next, please. So when we're looking at the way forward, we feel that it is always important to strengthen joint MPDSR reviews. And why this is really also important is because particularly for when they are doing a joint review, if it is the intrapartum stillbirths, it's really important to have both maternal perinatal groups together in the same table. So the reviews are important to be done. As I mentioned earlier, it's a continuous mentorship for the cause assignment, because just one time getting them to do the cause assignment in the capacity building workshop is not enough. Ongoing mentorship is really crucial. It's important that we encourage facilities, district provinces to use the scorecard to inform decision-making and targeted interventions. And I really appreciate and like what Anoma just laid out about the different interventions and the high impact one based on that. It's always important to strengthen the response of MPDSR, because if just by measuring it's not enough, it has to be correctly assign the cause of death and link it with the response. And it's not enough to have just the response plan, but it has to be implemented, and more important, it has to be followed up. What is really, really crucial, and I always like to highlight, is a no name, no blame culture, so that it's a safe environment where everybody is really working towards a similar cause of improving quality of care in the facility, in the district, in the province, to prevent future stillbirths. And that should be like, we should not be, we should be having no stillbirths. I mean, that should be our main goal, and we should be all working towards that same cause. So with this, if there are any questions, I'm happy to answer. Thank you so much.